Hello guys, welcome back to my channel. In this video we are going to talk about pulmonary embolism and pneumonia. We can go very deep to these topics, but not really for the krok. I will tell you some tricks about these topics which can be solved easily. So the questions can be solved easily. So let's start with the pulmonary embolism first. So here is a photo showing pulmonary embolism. The pulmonary embolism simply means that a clot gets stuck in the renal arteries. Probably originating from the deep veins and deep veins of the legs. We all know that when the clot or embolus gets stuck into the renal arteries, the lung tissue starts to get damaged because of the lack of oxygen or lack of blood supply. Let's see what it is, how we solve the question for this. So pulmonary embolism, it's a condition where one or more arteries in the lungs become blocked by a clot, or let's say embolus, so which is typically originating from the deep vein in the legs. We also call it DVT. Symptoms we will see. One thing is to remember the sudden shortness of breath. A lot of lungs pathologies are there, but there are only few pathologies are there in which sudden symptoms will appear. So in the pulmonary embolism, we can see sudden appearance of the shortness of breath, a sharp stabbing kind of chest pain, a cough, irregular heartbeat because of the blockage. Now the pulmonary and heart systems are connected, so we'll see the heart system as well. So dizziness or fainting because of the blocked blood supply to the renal arteries and hence to the body, and leg pain or swelling which is common in DVT, cyanosis. Let's see the question for better understanding. So a 55-year-old patient is having acute lower extremity thrombophlebitis. So on the 7th day, suddenly developed, this is something highlighting for the embolism, suddenly developed pain in the left part of the chest, dyspnea and cough. Temperature is okay, respiration rate is 36. So the person is having a very severe respiration rate, like he's trying to breathe, but due to the blocked supply he is unable to do so. So diminished breath sounds without wheezing. Diminished breath sounds, why diminished? Because there is no blood supply on some area, on some particular part of the lungs. So the area which is having no blood supply will not take part in respiration anymore. So when we will try the auscultation or we will see auscultation or percussion, we will see diminished breath sounds without wheezing. It says pulse is high because the body is trying to cope up the loss of some lobe which is not taking part in the respiration. The thready pulse is thready. Arterial pressure is severely low. So when there is something stuck in the arterial system or arterial supply, the arterial pressure will reduce because the heart cannot pump properly right now. And another hallmark is ECG findings. So Q2S1 syndrome, this is seen in pulmonary embolism. We are going to solve a lot more questions with the similar findings, like those sudden findings, the thrombophlebitis or DVT history, or the severity of the patient, like the arterial pressure, or this ECG finding. We are going to solve a lot of questions with this similar pattern. Let's see the next question. In the next question, this is something infarction. Infarction is something like the complication, as a complication that the part of the lungs which were just damaged before in the pulmonary embolism is now just got non-functional, which will not function anymore. There is a sudden the patient shows the profile of the pulmonary embolism itself, but some things to remember. There is sudden thoracic pain on the right with expectoration of the pink sputum. Pink sputum, you can remember that the answer will be pulmonary infarction, but the profile is the same as pulmonary embolism. The person have fever on the 4th day after surgery of cystoma of the right ovary, dullness of the lung sound on the lower right, isolated moist crackle can be escalated in some area, So the diagnosis which we can make is pulmonary embolism, and as a complication, so as a result, or as a prolonged blocked supply, or a prolonged embolism, we are going to see a non-functional part, which is simply termed as pulmonary infarction. Let's go next to the question. After significant physical exertion of a 66-year-old man with DVT of extremities, or we can say thrombophlebitis, has complained about the shortness of breath, intense pain, which we talked about in the definition part. So intense pain, sharp stabbing pain, this is something is the character of the pulmonary embolism. Marked palpitations. The person's condition are grave because some part of the lungs is not taking in part in some lobe is not taking part in the respiration. Cyanotic because of less of blood supply. Cervical veins are swollen. BP is severely low. Again, we see the same profile, that pulmonary embolism, the severity grade of pulmonary embolism is very high. Like the condition of the patient will be very serious most of the time. So the diagnosis which I made is pulmonary embolism, and what we are going to do as an investigation, so this is a selective angioneurography. So let's move next. This is for the diagnosis of pulmonary embolism, that angioneurography is the method in which we apply the contrast in the we fill the contrast in the renal arteries, and wherever it's the blockage through the x-ray, we come to know that where is the blockage exactly, and how the renal system how the pulmonary system is taking part in the blood supply. Wherever it will be the blockage, it can be removed. So next question, and question related to pulmonary edema. So also says pink sputum. 65-year-old patient have asphyxia, cough with the pink foaming sputum. So when there is a sputum, pink sputum, so this is already the sign of fluid accumulation in the lungs. Pink sputum, why pink? Pink because some RBCs are there. So when there is some fluid accumulation in the lungs, which is non-tolerable for the lungs, so there is some sort of leakage of the blood into the sputum, or so the sputum gets to be pink due to some presence of RBC or the blood, which we can say. Sensation of lack of air, fear of death because the pain is real. Orthopnea is something typical for pulmonary edema, because in pulmonary edema the fluid amount is actually too much. So when the patient will lie down, he will find it painful. So difficult breathing while lying, also fluid in the alveoli, it means. Acrocyanosis, he is covered with the cold, sticky sweat. Respiration is harsh in the lower part of the segment. There are wet, finely vesicular and moderating vesicular crackles. So for the pulmonary edema, the krok question highlights the word crackles most of the time. As we can see, the pulmonary infarction or the pulmonary embolism had a different kind of profile, with the history of DVT, some sort of edema in the legs, but in cases of pulmonary edema, we are going to see crackles. This is also a serious condition. Respiration rate, we can see 40 of the patient. It is also a serious condition. Heart sounds are muffled because the cardiac and pulmo system works together. So if one system gets to be affected, the other will get affected simultaneously and very faster. So a gallop rhythm on the cardiac apex, we will mark the diagnosis pulmonary edema. Next is fat pulmonary embolism. So first of all, let's see the definition of it. Fat pulmonary embolism occurs when there are a lot of fractures of the bone marrow. So what happens is the fat from the fractured site or from the bone marrow start to enter into the bloodstream. How such thing can happen? Multiple fractures can happen due to the risk of trauma, any multiple fracture already. And also for example, femur is the largest bone. So if femur starts to have some sort of fracture, so there are a lot of chances for the fat embolism. So let's see the question. A 32-year-old called cerebrocranial trauma, closed right femoral trauma, closed chest trauma. So the question directly highlighted whatever we wanted to see in the question, that there are a lot of fractures are there. So again, the severity grade is really low. So a BP diastolic BP is 60, is severe, pulse is severely high, respiration is high. So 2 hours later, the skeletal traction was performed under tropical lidocaine anesthesia. Patient condition became even worse. Face and neck became cyanotic. The blood pressure even reduced. So this is about this is like a shock right now. This is even more severe right now. Heart rate 160 is so severe. The respiration is 44. So what complication would have occurred? So even after the traction which they performed, the conditions did not improve. So we want to mark the answer as fat pulmonary embolism. Let's go next. Another question over edema. Some patient is there, elderly patient with the history of anterior MI, developed the asphyxia attack, diffuse cyanosis, heart rate is 100, blood pressure is just fine, it's fine. Auscultation revealed. So this finding is important for us, as I have told you that most of the time the krok question will highlight crackles for the pulmonary edema. So fluid accumulation in the alveoli simply means crackles. Let's say one more question. So the main thing in the question to see, which we have seen already, the lower leg is edematous. The main thing which I marked incorrectly before was we are supposed to understand when it says lower leg is edematous, we are supposed to understand that it's the case of DVT. It won't the question want to highlight. However, even if we do not remember this thing very well, we got our hallmark finding, the deep S wave in lead 1 and AVL. This is one of the hallmark finding for the pulmonary embolism, which is also known as the thromboembolism of the pulmonary artery branches. So picture we have seen. So let's go next to the pneumonia. This is a photo showing pneumonia. So what happens is, as we can see in the photo, it's simply an infection that inflames the air sacs in one or both of the lungs. So they get filled some sort of fluid which will cause problem with the respiration. So let's see it with the proper definition. Let's see the symptoms and let's see how to prescribe the drugs in pneumonia. Basically, the examiner love to ask the question about the drugs, which drugs you will prescribe for such particular case. So let's see the pneumonia with definition now. So pneumonia is infection that inflames the air sacs in one or both lungs, which may fill the fluid or pus, can be caused by any bacteria, any viruses, or any fungi. So symptoms will be cough. Sputum can be a lot of type, not just green, yellow sputum can be rusty also. It depends which type of pneumonia is there can be a lot of types of sputum, but rusty is specially highlighted in the corpus pneumonia probably. So fever will be there. The profile of fever is always we see in the cases of bacterial infections. Shortness of breath because the fluid got filled in some of the alveoli. Fatigue, easily the person will get tired because not the enough oxygen supply is there. Nausea or vomiting. Let's go and see the questions. So the profile of the question explains the corpus pneumonia. So 38-year-old man is ill from 3 days. He explains the disease that he got cold. He got overexposure to the cold. The patient have high fever, general weakness, sweating, cough Cuff was initially dry, but within the last 24 hours, a small amount of rusty sputum was produced. So, rusty sputum in such cases, the pathogen behind it is Streptococcus pneumoniae. So, rusty sputum. Rusty is a bit means RBCs are there. Some sort of RBCs are there. That's how the sputum got rusty. So objectively, the patient having dull sounds in the lower pulmonary lobes, the auscultation detects the bronchial breathing. So remember, when the question says about rusty sputum, this is the profile of corpus pneumonia. Let's go next. So in this question, you can read the question. 19-year-old having dry cough, muscle pain, fever, sore throat, and respiration is harsh. Leukocytes is this much. So leukocytes left shift. This is something about highlighting this. So when to give penicillin antibiotics and when to give second generation macrolides, I'm going to tell you about this right now. So when there is a leukocyte left shift, like there is a problem with the WBCs, so in those cases we are going to mark the penicillin antibiotics. And when there is no problem in the CBC, like the question explains, 12-year-old child diagnosed with bilateral pneumonia of mycoplasma etiology with mild disease course, and what drugs must be prescribed. So the question didn't really ask or tell about the problem in the CBC, so go with the second generation macrolides. However, when the question says leukocytes left shift and the X-ray finding, it says that low intensity focal shadows in the lower segment of the right lung, pneumonia can occur in this lobe as well. So in the right lower lobe, penicillin and antibiotics we are going to prefer when the leukocytes left shift will be given. So when there is no problem in the CBC, prefer to give second generation of macrolides. For the pregnant woman, prefer amoxicillin. Pregnant woman, rest other things are the same: crepitation, moist, crackle. Rest other things you can pause the video and read the question carefully. So we will prescribe a pregnant woman having pneumonia, will prescribe amoxicillin. The patient, another profile is there. The amoxicillin was not given in the question. The question is showing the perfect profile of pneumonia, having yellow sputum as defined in the highlight, as highlighted in the symptoms part. So the auscultation detect moist crackles on the left, the CBC are affected, there is fever. So the consolidations in the left lower lobe we can see. So in such question, amoxicillin was not given in the question, so we prefer azithromycin in such cases. One more last question is there. So a young patient was treated in the hospital. So he have fever now, chest pain now, which is worsened by the breathing, cough, and this is brown sputum. It's really brown. So on the 7th day after the treatment, the X-ray shows some infiltrate. Pneumonia is really common for the lower lobe. As we can see, we saw two questions. This is the second question. So this is the case of hospital acquired pneumonia. In the cases of hospital acquired pneumonia, prefer the answer cephalosporins of third generation. So these are the questions which I saw in krok exam for the choice of treatment. Most of the time the examiner asks about the which drug of choice you will prescribe in such and such cases. Instead of asking if it is which type of pneumonia, he loves to ask about which drug you will prescribe. This is it with this video. I hope you enjoyed the video, and now the questions related to pneumonia and pulmonary embolism will be easier to solve. Thank you so much. Good night. See you with the next video.